Hey Cam followers, surprise, surprise, it's Wednesday night. Every now and then we catch you out and we chuck in something new. So this is a bite-sized Facebook Live with the lovely Dr. James Hunt. We are here for 30 minutes rather than the full hour. And we will be here this Wednesday, next Wednesday, and the following Wednesday. Just bringing James's expertise right to your screens. Tonight, we're going to be talking about what is possible in a chronic pain consultation. We're going to touch upon first opinion, speciality, and mobile services. But first, I'm going to get James to tell us a little bit about himself. And then I'm going to do a little advert about our book, and then we're going to get on with it. So go for it, James.
Oh, great. Thank you, Hannah. Yeah, you've limited me to 30 minutes because obviously we end up talking for hours and hours usually. So I qualified in 98 from the Royal Vet College. From very early on, I was interested in pain management, acute and chronic. And that's just developed over time, really, and have found myself doing master's and PhD research in different aspects of pain in dogs and cats. And now I see a reasonable proportion of my workload is seeing pain cases. Yeah.
And as you say, a very mixed batch in that we have a tendency to think everything revolves around OA, which is what I do. Everything's OA. But actually, there's many different areas where pain management's important. So we've got more visceral pain, so, internal organ. We've got cancer-related pain. Yeah. We've got neuropathic spinal pain. So there's a lot more out there, which James is great at. So please enjoy these 30 minutes. Do ask questions. We are going to be fast because you get to see him next week too. But first, I'm going to tell you a little bit about the CAM book. As most of you know, CAM is completely self-funded. We are independent so that we have the ability to say, yes, we believe the evidence suggests this works, or no, the evidence is not there to suggest it works. Whereas if we were to take sponsorship for things, we would struggle to maintain that independence. So we have to fund ourselves. And this is one of the many ways that we fund ourselves. This is an illustrated children's book. It's got my dog, Holly, in it. And it's there to try and improve children and families' understanding about how pain is expressed, how common it is, and ways that you can adjust yourselves to make sure that you don't put this lovely dog in the position where they might choose a method to say, get off, that hurt. So I think it should go out with every single sale of pain medication to protect families, protect children, and most importantly, to protect dogs. It is available in the shop, camonlineshop.com, and I'm sure Cambassador will give you the link in the thread. So now we're going to crack on. We're going to talk tonight about what is possible in a pain consultation. And first of all, we're going to get James to kind of go through what he does in his pain consults where he works currently. So he currently is at a speciality centre, CAVE referrals. And I'm going to get him to talk through his process. We're then going to skip into what out of that process can be achieved in a first opinion consult to inspire everybody, clients, vets, professionals. And then we're going to talk about what's possible in a mobile service. So crack on, James. Tell us what you do.
So what I do, so I guess I see two different types of case broadly. So one is where a patient has had a diagnosis. So it might be from a primary vet, and there's a radiographic or CT diagnosis of arthritis. Or it may come from, an internal referral from the hospital. So a diagnosis of a neurological pain or something like that. So we've already got a diagnosis, but then we want to understand how that's affecting the animal and what methods we might be using to address that. And then I suppose the other group of patients are ones who have maybe had very extensive workup, and all of the results have been quite inconclusive. So we believe that there's pain there. The patient is giving us signs that suggest there's a painful focus, but we've not been able to identify it with any of our investigations so far. So that's slightly more detective work in trying to understand what's causing this problem. And you know, it might not be there all the time. It might be something that's intermittent, and we've then got to try and piece together, you know, what the owner's telling us, any video that they've recorded, which is really helpful. You know, any patterns they've noticed in the behavior, to try and understand what might be driving that. So those are my two broad categories of cases. And I suppose in both instances, what I'm trying to do is establish what is contributing to pain. So although we've got a diagnosis of maybe elbow arthritis, is that the sole driver of pain in this animal, or are we also looking at muscle pain, or, you know, is there something in addition to the arthritis that we should be thinking of as well? Maybe a chronic disc disease or something like that. So in the first instance, trying to understand what mechanisms might be driving pain in this animal, and, you know, rank how important each one might or might not be, which can be difficult. And then try and understand what impact those pains might be having on the animal's quality of life. So how's it affecting its sleeping? How's it affecting it interacting with people in the household? How's it interacting with other animals in the household? So that we can try and create a more global picture, I suppose, not just of the physical sensation of the pain, but what it's actually impacting in terms of the emotion and the cognitive function of the animal as well. What I try to do.
No, I was doing that today, not as great as you. But well, I had a lady come in and she hadn't done any objective monitoring. So we didn't have any references to kind of go back to, no numerical figures, no questionnaire had been filled out, no good day, bad day diary, etc. Yeah. So when I asked her, how do you feel your dog has improved since we did the medication adjustment 3 to 4 weeks ago? And she did what all owners do, which is, yeah, I think it's better. And you're like, right, let's go emotional level, let's go general physical level, and then let's go focal level. And I was like, right, so let's think, how is your dog? Is your dog suffering? Is your dog emotionally good? Are they engaging? Are they, you know, wanting to spend time with you? Because she'd said, yeah, he's still limping. And you can immediately think that our intervention hadn't worked. And I was like, right, no, let's rewind. And she was like, no, really, really wants to play, wants to engage, wants to spend time with us. I was like, so emotionally we're good. And she was like, yeah, I guess so. And I was like, what about overall physical capability? And she was like, yeah, we're going further, but the limp's still there. And I was like, okay, that's focal. Go back. What's our general? And she was like, yeah, we're generally doing more. There's more wish to do more. And then she was like, but the limp's still there. I was like, right, this is good. We're getting control of the bigger picture, and we're now beginning to hone down. And this is where maybe more targeted treatment is going to be appropriate. So we've got the general pain and suffering under control, and we can now start thinking about intra-articulars. We can think about laser, acupuncture, you know. And she was like, whoa. And I was like, yeah, I know. Pain's amazing, isn't it?
Yeah. And it is. It's really important that we don't just focus on, you know, what we've diagnosed, but we look at the rest of the animal as well. So but we also want to make the animal feel that he can do all the things he wants to in life.
Yeah, definitely. I'm gonna have to harp on about Duncan Lascelles, because, you know, we're best mates now and everything. And he was saying last week that the 3 areas that he feels that we're going to make massive advancements in the next decade is going to be our objective monitoring with the wearable devices, and being able to more precisely quantify deterioration and improvement. Next one is going to be more targeted treatment. So he thinks we're going to excel in our intra-articular type therapies, more specific. And then the other one, which I loved hearing, was we're going to realize the importance of sleep, engagement, distraction, movement. And I was like, oh, so many people are already on that. Amber Batson. Yeah. So, okay, back to your chronic pain concept. I've started tangenting again, haven't I? Sorry.
Yeah.
So what happens? The person arrives, or do you send out material beforehand?
So at the moment, we do that just before the appointment. So yeah, we hopefully need to get a better system in that we send out the questionnaires before. So I'd like to do them almost a week before the appointment, and then again at the time of the appointment, so we can try and get a baseline over time, because it does, these are diseases that do wax and wane. So we, you want to try and get as representative a picture as you can. So we do use some questionnaires to rate the pain. We do usually use a quality of life scale to give us an indication. It doesn't give us hard numbers. It doesn't say, oh, this is terrible quality of life, we need to have a serious discussion. But it highlights areas that we might need to focus on and make sure that we're catering to those. So we'll do those. Usually chat for half an hour or so to get a full history and try and understand, what makes the disease worse, what makes it better, any medications that what diagnostics we have or haven't done, and whether those are an option. And then usually by that time, we've been feeding the patients a few treats and things, so they're a little bit more relaxed when I get to hands-on and get to assess, joint function, muscle mass, muscle tension, joint range of motion, all those kinds of things that we assess in looking for pain, and trying to subjectively, but with a bit of a clinical hat on, identify painful points. So then once we've done a history, we've done a physical examination, we can then talk about whether or not I think any further diagnostics are warranted. In some cases that might be, and people are happy to go for that. In cases, people think, oh, actually, I don't want to give my older dog a general can undertake more investigations. I just want to try and treat what might be the most likely thing, or what you think is the most likely thing, and that is a equally valid approach. It can be, sometimes it can be helpful if we can do the investigations and get a clearer diagnosis. It might help guide our treatment a bit more. But if we're suspicious on the clinical exam that it's arthritis, arthritis is a very common condition, so there's nothing wrong in treating on the basis of the clinical signs and clinical suspicion that we've got an arthritic patient. And then, but in that kind of situation, we just need to be mindful, if we're not getting the kind of results that we would have hoped for, we do reconsider the diagnosis.
That's such a key point, and I think that's a massive take home from today, is that yes, it is acceptable to start a management plan without imaging, because we get asked this a lot by owners. But if you believe it is arthritic pain, which is a very specific kind of pain, inflammatory nociceptive pain, then you really would expect it to respond to the foundational pain management strategies. And if it doesn't, you have to go, why? And therefore that might be a stage where you go, we need more info, otherwise we're just stabbing in the dark.
That's right.
So I think owners just need to know that we are flexible. We really try and work with them, but there's times where we go, I haven't got magic wands, and I haven't got x-ray eyes. We're going to have to. So that's cool. And then what can an owner expect from you after that? In that, do you do any treatments during your chronic pain consultations, or is it all about elucidating the problem, looking at a pharmaceutical plan, giving lifestyle advice? Do you use anything else?
Yeah, so I use acupuncture, and just starting with laser now as well. Kind of prompted by my own dog, who doesn't tolerate acupuncture. He's slightly needle phobic. So the laser obviously isn't associated with that same sharp sensation. But I don't know. I would say probably 98% of dogs tolerate acupuncture quite successfully. I think some don't, in that they've got very severe myofascial pain, and just the sheer well, even a lot of touch can be uncomfortable for them. So I think in those cases, acupuncture is probably not the modality that I would go for. But yeah, hopefully laser then can be a bit more appropriate.
So and I think that's another massive take home there, guys, is that none of us know exactly what your dog is going to respond to. And a lot of chronic pain practitioners will have a number of tools within their toolkit. So they'll have pharmaceuticals, the medications, they'll have weight advice, they'll have lifestyle advice, they'll have home advice, they'll give you that, but then they might, like James, have acupuncture, they might have I love manual therapies, they might use ultrasound, they might use PMF, pulse electromagnetic field therapy, they might use other tools, they might be lucky to have hydro. There's many other things out there that they combine. So what your neighbour Mabel by the poo bin has with her dog might not be what your dog has, and I think that's really important to know as well.
Yes, very much. So that's one of the challenges, and also what makes these cases really interesting is that they are all individual and have, they respond in individual ways to different treatments. So we definitely, review the pharmaceutical plan. We might add something to it. We might even try and rationalize it so that we can, I guess, optimize our treatment. So if we think things aren't necessarily helping, we might try withdrawing them. And again, different drugs work for different pain conditions, but also for different individual patients. And we are not at a stage yet that we can predict which patient will respond to a certain drug. So there's an element of trial and error. So it can be, it can be a case of having patience while we're going through this process. But going back to what you were saying about the objective monitoring, that's where that's so useful, because if, I've got a dog with a chronic pain condition, and it's so easy to say, oh, I think he's a bit better. I think, well, maybe he's a little bit stiffer today. I'm not really sure. So if you've documented it, you can go back and look and be reasonably confident. And of course, there's other reasons the conditions are going to get better or worse, not just the treatments, but the natural progression of the disease. But it gives you more of a handle on what your treatments are doing.
Definitely. And what kind of frequency do you see people back? And then we're going to jump from your speciality now to when you can remember the days of being first opinion practice, what you feel people can expect in a 15-minute high pressured busy practice. So how often do you see people in your referral setting? What kind of frequency?
Well, so initially, if we're starting, say, an acupuncture or a laser treatment or something like that, we'd usually try and see them once a week for the first, almost as an induction kind of period. And, we'll be using those physical treatments a lot for muscle pain or myofascial pain. So we almost try and address that in a fairly intensive way for the first 4 weeks. And then often we'll drop them down to, an every 4-week treatment, or maybe even longer, and kind of review things on a monthly basis. And it depends very much on the patient. Some will continue coming every month, some will extend to every 2 or 3 months. Obviously, now we've got the Librela treatment. Some animals with osteoarthritis are having, or silencia in the cat, and that's suggested a 4-week treatment interval as well. So that kind of ties in often with what we're doing in terms of monitoring these patients.
Yeah.
And I think a monthly interval is quite good. It gives you a sufficient window to see how they've done over that period of time. They might have had a few ups and downs, but it stops things, sliding. So they've not got a bit stiffer 1 month and a little bit stiffer the next month, and a little bit stiffer the next month. And you see them 3 months later, you think, oh my goodness, we could have done something a bit sooner to address this.
No, I was hoping that you'd say that, because I think you can have owners fall into two extremes. You can have the owner that wants to be seen weekly because they were worrywart, and but that's not going to give the medications a chance to work, and you're almost feeling like a clinician going, they want me to change something else, and I can't. I've only given it 7 days. You've got to give time and put all the other game changes in place: the weight, the lifestyle, the exercise. And then you've got other owners that want to be seen once a year, and you're like, no, this is a disease that's going to change, so we need to stay on top of it. So that's cool to know. A couple of questions before we go into first opinion, because you've only got 10 minutes left. Have you any experience with Daxocox? Have you started using it? So for anybody that doesn't know, Daxocox is a new non-steroidal on the market, and it is designed to be given once a week. So it's a completely new concept. There has been a medication known by, it's called mavocoxib, trocoxil. It's been once a month, but there's never been one that's once a week.
I haven't used it actually yet. No, I've read the product literature, but I've not used that yet. I suppose there's some cases where I could see that would fit quite well for people, but I suppose a lot of people are sort of used to the routine of daily non-steroidals if their animals have got osteoarthritis, and you pop it on their food in the morning, and it's part of your routine. So yeah, I haven't used it yet. I know what my memory's like because I forget to put the bins out from week to week.
Yeah. So it can work both ways, can't it?
Yeah.
Yeah. No, I agree. I think this. I know of some clients that would find that really useful.
Yeah.
And I know I've got some clients that won't stick to every 24 hours, or they sometimes they do 12 hours, sometimes they do 8 hours, and you're like, come on. But I've got other clients that they would just forget in total. Next question. If pain is under control with medication, would there still be a limp on a walk, or is that the sign that they are still in pain?
So you can definitely have a limp without any pain. So sources of causes of lameness is either there's a painful focus or it's a mechanical. So it might be a contracture of a muscle, or it might be, I suppose, if you had kind of ankylosis of a joint, or had a surgical fixation of a joint so that it didn't move in its normal range of motion anymore, you'd still have a limp, but there might not be any pain associated with that from the joint. But we know if we've got an altered gait, we've got different, we're taxing the muscles and the other tissues in the body differently. So we may have pain not at the joint, which is the source of the limp, but distant to that because of the adaptations that we've made, if that makes sense.
Definitely. And I think that really describes that when we're managing these cases, palpation, observation, and history is so important. And Cam's for a long time been wanting to look into telehealth. We've wanted to do an individualistic telehealth service to the people that follow us. And something that holds us back very strongly is that palpation is such a big part of assessing pain. But yes, mechanical lameness is possible without pain, but really you would want a really good clinical examination to be able to truly say that. Yes, Caroline, totally agree. You need to always make it very clear to your clinician what you're capable of doing. And I did a really cool lecture with Gwen this week about concordance to treatment plans. So owners being able to stick to treatment plans. We've got to make sure that we don't set you up to fail. So if you are not able to stick to once a week laser, or if you can't give a tablet twice a day, you need to tell us, because we're almost setting you up to fail. And then you lose faith in us, we lose faith in you, and the dog suffers. So always be really clear about what you can commit to. So let's really quickly touch on first opinion, and then we quickly going to look into something of the future, mobile. So what do you think an owner can expect from a first opinion pain consultation with the knowledge you have?
I think you can actually do a lot in first opinion. You know, particularly if you've got an interest and you've you know, maybe had a bit of training in massage treatments or acupuncture or physiotherapy and those kinds of things, and you're familiar with assessing musculoskeletal, you know, systems and looking for changes in those. The difficulty is the time pressure, definitely, because, you know, animals may be tense because they've suddenly come into this new environment, which makes your examination more difficult. You have a limited time to take the history, but, you know, there's definitely strategies where you could either the owner could talk over the history, or, you know, there'd be a questionnaire to go through with a nurse before the appointment with the vet. So at least that information is all sort of codified then, and you can quickly skim it. As we were saying, the pain questionnaires, things like that, you can send out in advance of the appointment, so that you've got that kind of background information already, and then you can marry it up with the physical presentation. You know, and I think what you can do is monitor these patients over time, and if you're not getting the results that you're expecting, then think about, you know, speaking to somebody in a specialist center, or you know, somebody that's in your local area who does a bit more of this kind of musculoskeletal work, whether they're into sports medicine or, you know, rehab, any of those kinds of things.
Yeah, definitely. So there, I'm quite lucky. I've just come back to clinical practice because I had a year off doing CAM, and then I'm really lucky that the practice I'm in want to expand their chronic pain services. So they're really letting me experiment with what is possible in first opinion, and we're playing with using the CAM resources. So an email going out before with links to please watch this live, please read this section of the website, please fill in this form. So they get an email before, and they can just quickly hop and do these things that, as you say, prepare them. And we're also using the CAM Essentials course that we've created. So owners come in educated prior to the consultation. So they do these 12 short modules, and they understand the importance of weight. So they're already engaged. You don't have to fight that fight. And they understand how exercise can be good for pain, but it can also be bad for pain. So understanding how you can vary exercise. So we're trying desperately to equip them with foundational knowledge prior to the consultation to get the most out of that consultation. But it's quite a new way of thinking, and owners are like, you want me to do homework before I come with you? But
it pays off. Yeah, it definitely pays off. It, you know, it maximizes their benefit from seeing the vet in that instance, and, you know, they may already have come up with questions that they want addressed. So rather than leaving the consultation thinking, oh, I wish I'd asked that, they've got that opportunity. And you know, I think lots of nurses are so engaged with this kind of stuff as well. You know, the weight management, the lifestyle adaptations around the home, that there's definitely, you know, collaborating with nurses on these kind of lifestyle clinics and advice.
So if any clinicians listening to this going, oh, I just want to be in James' position, I want to be able to have an hour, I want to be able to have time, I want to have somebody help me send a questionnaire out beforehand. If you're one of those practitioners and you're thinking, oh, I need more help, then just get in touch, because we've got resources that we can help you with. So info@caninearthritis.co.uk. So info@caninearthritis.co.uk, and we will share with you resources that you can readily tap into, so you can also pre-prepare your owners, so that 15-minute consult works. Now, if you're an owner who's thinking, God, actually, I really feel that I'm rushed with my clinician, I feel that I don't get to what's really important to me quick enough, I feel like I'm fuddled in my head, then also look at doing something like the CAM Essentials, or download the CAM booklets and prep yourself. There's a lot of stuff on the website. Download some resources. Go with your suspicion of chronic pain PDF. Go with the what has changed for my dog questionnaire. Go with information so you can actually work with that condition well. So now let's move on, because we're breaking our time limit, but I want to talk about how chronic pain services are becoming quite exciting, because we could go mobile with this, and it's something that you're looking into, isn't it? Which is quite exciting.
Yeah, yeah, it is. Yeah. So, and I guess that was partly prompted by chats that we've had, in that we've talked about the difficulties of examining animals in a clinic in a strange environment, where there's, people that they don't know, there's noises that they don't know, there's other animals that they don't know. And also we've talked about how important it is to be able to assess the environment that we're asking the animal to function in, which, we try and do when we take a history. We say, do they have to climb stairs to access resources? Do you have, hard floors, or do you have carpets? But if you can go and see that for yourself, you instantly go, oh, I see, this is a challenge for your pet. What can we do about it? Because with the best will in the world, we won't always ask the right questions, and it may not seem, or it might be so obvious to an owner because it's part of their daily life, that there's no need for them to mention it to us. But actually,
Countless stories. I could, when we drink whiskey together at some point soon, I would just tell you the amount of houses I went to where the owner was just oblivious because the dog had grown up in the house, and falling down the back step, falling between different height rooms, when you have the kitchen that drops down into the living room, slippery surfaces, the front door where the postman drops off the post is complete laminated floor. And I was just like, there. And they're like, what? But you do have a lot more weight to make these suggestions when you're there pointing it out. Remember one day an owner wouldn't listen to me about the floor. They just couldn't see it, and then I got them to lay down on the floor, and we looked at the light shining on it, and she could see where the dog had walked in with wet feet, the slips where he'd placed his foot and it slipped away. And she was like, oh my God, you're right, he doesn't place and move on, he slips.
Escaping
really powerful to be able to offer the advice in their home environment. It's exciting.
So I think that's a major benefit. I think the chance to examine pets when they are feeling more relaxed and content, and they're more willing to let you kind of examine them thoroughly is really helpful. And it takes that. I've got a dog that doesn't like going to the vets at all, even though he comes with me. So I'm not sure what that says about me. But that having to travel to a clinic can be a barrier as well for pets that need treatment. So hopefully offering that kind of service is going to mean that we can get more pets treated.
I think so. And I think owners are going, my experience, and I ran my clinic for 2-3 years, where owners were more relaxed. Owners asked more questions. Owners dived into what would be overlooked in a consultation because time pressure. Definitely got better relationships so that they felt they could ask me more weird and wonderful questions.
Yeah.
They've got the continuity, which is really important. And guys, take our message when you phone up for your appointments. Don't just take any old appointment. If you want to see the same clinician, say, when is James on again? And that receptionist will do their best to find when that, vet is on duty again. We see it a lot in Holly's Army, people saying, oh, I just have no continuity. We're like, you've got to ask for it. They can only say no. Ask to see the same vet. So now this is really exciting, and I think it just shows that the field of chronic pain management is really beginning to take off, and we're talking about doing a big congress. It'd be amazing. We're going to do it.
Yeah, I think that's what we need to aim for. Yeah.
Yeah.
But yeah, there's lots of really great, enthusiastic people coming into this field at the moment, and I think there's been a realization as to how important it is and how widespread the problem is. And so, we're slowly starting to address it.
Yeah.
But we haven't got the answers yet. It's still very much a case that we are learning how to incorporate all these different things. So the physiotherapy and the lifestyle changes and all that kind of thing. It's not, unfortunately, there isn't a magic bullet. So it's a case of trying to address lots of different areas.
Yeah, definitely. And I find that when I've been on the phone all day because I've just been back. I had COVID, so I wasn't at work for a while. So I've got a message list. Oh, no. When you go back, you go, oh God. And so I've been on the phone all day and finding I'm saying the same sort of things, sharing the CAM resources. And you really are trying to impart so much information about a very complex disease in such a little amount of time that it's nice to see that more time and consideration is being given to this, because at the end of the day, the figures seriously stack up. Very few dogs are going to avoid a painful condition at some point in their life. We know that they're quite complex pain presentations with huge amounts of different interventions. So realistically, for the dog, for the client, for the vet, and for the practice, it's all win-win-win. At the end of the day, everybody's a winner if more energy and time is spent on these cases. So we've got a question here that I think we'll end on. It's a long one. So we have a 4-year-old dog with signs of beginning OA in his toes and other issues. Amputated toe due to infection, one cracked toe with joint completely overgrown with bone spurs, overall sensitive legs. Our vet has decided to not put him on pain meds because he doesn't show lameness, but he is sensitive on the leg that has the toe amputated and another with bone spurs. How often a dog in this condition should get consultations, and what are the signs when pain meds should, and then we've run out of space. So what's your kind of thoughts on that?
Well, I wonder if it would be worth, in that kind of instance, doing one of these pain questionnaires, just so at least as a baseline. So if the dog isn't painful now, we can actually see if those scores start creeping up. That could well be an indication that the dog needs to start some pain medication. I mean, I would think probably maybe 4 times a year, something like that, just to keep an eye on it at this stage. But I would definitely think it's worth doing some kind of objective questionnaire, so that at least you've got that baseline data to work off.
And I think one of the questionnaires, like the Canine brief pain inventory, because it has the pain interference score, which is going to be talking about like the lamenesses and the capability, but it's also got that pain severity score where it's going to look more at like the emotional impact. And for us vets, it's very difficult to really quantify pain. And so therefore we do rely on things like lameness to kind of give us some form of objectivity. And that dog might be expressing their discomfort by being less engaged, being distracted, being less tolerant. And you don't have the ability to get that across to your vet in that circumstances. But if you were to use a questionnaire, you could really highlight to them that your dog's mood has dramatically changed. And then that might flick a switch in the head of, okay, you know, this is bilateral. I'm not going to see an obvious lameness. Doesn't mean it's not there.
No, exactly. And then you might go down the route of, you know, a trial pain or analgesic therapy, you know, maybe for a couple of weeks to see if you do see any difference then in the recorded pain scores. But yeah, lameness gets a lot better when you go to the vets quite often, because you've got that surge of adrenaline, you know, they're distracted. Yeah.
It's really difficult.
Sometimes it can be difficult to get a realistic picture of, you know, and then they'll go home and they'll be hopping lame.
Yeah. I did, you'll be proud of me, I did a live event for Grisha Stewart, which is a canine behavioural kind of education platform. And it was all bringing it together of what it's like being the vet. So I did a huge amount of, this is the reality from my side of the table.
Yeah.
And at the end of it, I was supposed to talk for an hour, I talked for 2 hours. And they were like, it was nice because people were turning around saying, I'd not really thought of it like that before. And I feel like I could actually build a better working relationship with vets because I've now seen it from your point of view.
Yeah.
I think it's very important.
Yeah.
High five me.
There was a quick question popped up about what if you can't manage a weekly appointment? Yes. So yeah, I think, as we were saying, just being very clear that that's a limitation, because there might well be alternative treatments. So, you know, things like applying heat and things like that to muscles at home take time, but are relatively cheap. So, you know, it could well be that you discuss things like that, those kind of physical therapies, rather than, laser treatment or acupuncture or those kinds of things that need expensive equipment.
Definitely agree. A phrase I said today, and I was really trying to get it across on the phone, was, I can't tell you how important lifestyle and weight is, and it's free of charge, and you can do it tomorrow. And this lady was like, I got it. Like, seriously, you know, there is so much.
You're scary.
Oh, scary.
Yeah.
Enthusiastic, James. Enthusiastic.
Good.
Cool. And on that note, we're 12 minutes over. So thank you guys for listening.
Yes,
James will put his contact details in the thread. So if you want to know more about what James is up to, he will leave his contact details in the thread. I'll put it in the description. He's based not far from me, which I'm really pleased about. So he's more in the southwest, Taunton based, and I'm really, really excited for your new venture. So hats off to you. And we will be back next Wednesday where we tackle another topic. What was next week?
We're going to chat about foundational analgesics, I think, aren't we?
That's it. We're going to be talking about foundational analgesics and trying to dispel some of the fear, talk about the realities of appropriate use. Yes. Yeah. And then the week after that, we're going to go for a case where you can show people how you work.
How long does my gears take to work?
Not at all. Not at all. So, until next Wednesday, thank you very much, James. Tomorrow night, we've got one of my my colleagues who I went to university with in my year group, who's excelled, Dr. Simon Tappin from Dick White Referrals. He is on tomorrow talking about managing osteoarthritis when you've also got comorbidities of kidney disease or liver disease. So that is going to be a massive topic. And our lovely host is going to be Nikki. So please do join in at 7 o'clock tomorrow night. Till next week. See you later, guys.
Bye.